Thank you very much for having me. It's really great to be back. I think just seeing the amazing lineup of speakers today and also seeing all of you in the audience, I think is a testament to Prof. Cahill's ability to really convene such an interesting group of speakers with a wide range of expertise. And I think also speaks to the expertise that you have here locally at the Mater and at UCD because of the amazing innovative work that's being done here that I know all of us have come here really to see more of and to learn more about Ron, your leadership and what you've been doing with Classica and a lot of the work that you've been doing. So thank you for doing that and putting this all together. So I do have a couple of disclosures. None of the industry-related stuff am I going to talk about today, but it's really a lot of the work that has been done in our group really has been through the support of a lot of different societies and philanthropists that have made some of this possible. For those of you who were there at RCSI yesterday, apologies for a couple of the slides that are going to be in repetition, but really to try to set the stage here for the rest of the day, surgical data science is really I would say a collection of efforts that has really come together focusing not just on surgery, despite the word surgical being in the term, but it's really on anything interventional or procedural that we do in the hospitals. And so, of course, that includes surgery and has largely been driven by initial work that was done in surgery, but it's really meant to be a big tent term. So anything including interventional radiology, gastroenterology, cardiology, etc. It includes the intensivist doing procedures in the ICU, the emergency doctors doing procedures in A&E, and so it really is a broad-reaching field. And in terms of data, we want to think about the data beyond just what we're doing in the procedure itself, right? What happens before that patient gets to a procedure is incredibly important in terms of decision-making, and of course what happens afterwards is also important in terms of can you rescue ahead of a potential complication or make sure that this patient aligns with your expected outcomes for what you would expect for a given type of thing. And when we think about the sources of data, it's not just the patient. We want to think about the providers as well. So what's going on with the clinicians in the room? Can you measure things like heart rate variability? Can you measure things like galvanic skin response, cortisol levels, etc.? These devices that we're all kind of wearing now that give so much information about our health and well-being can also be used to better understand how we as clinicians are responding in the operating room. And the technology is far-reaching. We were just talking about the electronic medical record earlier, so thinking about that as a natural source of data, but then what are the other types of sensors that we have available to us that we're not really leveraging yet, right? So robotic surgery, obviously the robotic systems provide a lot of data on the kinematics and what's happening, all the sensors that the anesthetists have on the patients, and then on top of that, just things that we're using every day. So if you have a ligature device, right, that's measuring impedance, can we get that type of information to better understand how these devices are working and how we're safely doing surgery? And the goal overall is to yield quality improvement. And that can be in the traditional sense of improving processes and strategies. But I would say that probably the thing that many of us in the field are sort of aiming for is can we predict and prevent adverse events from happening in real time? And doing so through real-time decision support. Now, nowhere in this did I ever say the word AI, right, despite the title of the conference. And so that's to say that AI is a tool that enables surgical data science, but is not necessary to do so. In fact, a lot of the things that we do in surgical data science, even when we're analyzing data like video, can be done without using AI techniques, things like optical flow and whatnot. But it is an important tool, and it's becoming increasingly important and increasingly popular. So while there are a lot of definitions of AI, just to sort of ground us more generally for the conference, I think probably a broad definition that we could use is to say that AI is really any sufficiently complex software that can mimic, not replicate, but mimic human behaviors. And within that machine learning, where we think about the specific study of the algorithms and techniques that allow algorithms to learn from data, right? And in terms of the approaches that we're taking at a single institution, so at Penn, for example, we really have three pillars in how we have designed our efforts and how we're trying to push surgical data science forward. So on the one hand, as a clinical surgeon, right, so half my time is spent as a minimally invasive upper GI surgeon. I'm very interested in the application of these technologies into practice. And so a third of my lab works on applications of AI specifically for surgical guidance and education. And I'll show you a few examples of how we're trying to build that out. My other half of my hat is I teach in computer science at the School of Engineering there at Penn, and there we're doing a lot more sort of quote-unquote basic science work around methodologies, right? So what are new architectures or algorithms that we can leverage to better understand and enable this type of work to happen? And then a growing part of what's being done in my lab is really thinking about what are the downstream implications for how this gets rolled out for clinicians and for patients. And that, I'll be honest with you, I can't take credit for as a medical student that I had worked with when I was a resident. And he came and did a year out in my lab at Penn, and he was a former healthcare journalist. And he was really interested in these questions around what do patients think about these technologies and what do patients think about these technologies being used on them. And so I'll dive a little bit into that and sort of the growing body of research that we're building on understanding healthcare AI literacy and knowledge. So when we think about performance, right, we think about, did a patient do well? Right? Did they live or die? That's obviously one of the easy ones to count. But then we really want to understand how can you improve that performance. So I'm from Cleveland. The Cleveland Cavaliers are our basketball team. In fact, they started the season 15-0. And they just lost to the Celtics on Tuesday night, which is very depressing for me, but that's okay. We'll still win the NBA Finals, I'm sure, in June. This is an example from Microsoft where they are partnering with the NBA to try to better understand, can you quantify performance of individual players and things that are happening on the court? So this is actually a play from the 2016 NBA Finals when the Cavaliers played the Warriors, and this is the setup of how they were trying to pressure Steph Curry to turn over the ball. Right? And so they can actually look at each individual thing in terms of who was the player on the field or on the court, how much distance, you see the distance measurements, the angles, where the ball is moving to, and what is the likelihood of getting somebody to turn over the ball. And this is for a game, right, that like my 3-year-old plays, and then eventually people end up getting paid millions of dollars to play. This is not a life or death scenario, and yet we're able to dive so deeply into these types of metrics to better understand what's happening, to improve performance for the act of putting an orange ball through an orange hoop, right? And so then the question becomes, if we can do this for sport, like why can't we leverage this to improve what we're doing in the operating room as a team? Because what we do in the operating room is teamwork as well. And so as techniques have developed and are implemented outside of medicine, I think we have to look to see how can we borrow those techniques and grow those techniques with specific clinical applications. And so on the left is an example of Tesla's autopilot, which is heavily computer vision based. Computer vision refers to machine understanding of images and videos. Now, computer vision does not require AI techniques to do, although it has certainly accelerated its implementation. And on the right is an example of work that was led by my colleague Amin Madani, where we leverage similar types of techniques in computer vision to try to create real-time guidance systems for surgery. Right, so what you're seeing on the right there is an example of a computer vision algorithm that is highlighting in green to a surgeon, this is the safe place to do your dissection. And the red is, don't cut down here, you have a higher chance of yielding a bile duct injury or some injury to the duodenum or other critical structure. Now, that's all well and good, but much like when we look at a GPS, we might say, why is the GPS taking us this way? Right? So before you decide to follow your GPS, you may want to say, it's saving me 15 minutes on my commute, right? So if you're a surgeon, if you just get that and it doesn't tell you why, right, you may not be as inclined to listen to where it's telling you to go. And if we think about what we try to accomplish in surgery, if you're thinking about it from computer vision terms, there are certain things that computers try to do in terms of tasks. So at the basic level, it can try to classify things in an image. Right, so this is a grasper in this image. It may try to localize those for you within the image, detecting things like there's the grasper there in the upper left and the clipper on the bottom, or it may more specifically try to segment what's happening. So can you tell me exactly where those instruments are? And so it's been great to see that as these techniques have developed to try to better understand how we can use these types of algorithms, that the field in general has made a lot of progress. 10 years ago, the initial questions were, can you do these types of things? Now we know that you can, right? So when somebody says, I want to do this study, can I segment this structure? I don't even need to know what the structure is. The general answer is going to be probably yes, right? Because we know we can do those types of things. And so Pietro's here. He's done a lot of work on critical tool tissue interactions and segmenting anatomy. A lot of us in the room have done a lot of work on phase identification, and then the work that I just showed you on sort of safe and unsafe zones. But these are all things that have been developed for applications in surgery just in the last decade. And so to just sort of give more specific examples of this, phase identification is so important because when we try to teach surgery, right, you first want to understand what are the steps of an operation and what are you doing. Think about when you have a medical student come to the operating room with you, right? So this is an example of an endoscopic procedure, per-oral endoscopic myotomy that I had done with Oz when I was at MGH as a fellow. And so on the right is the image of the procedure where you're trying to cut the muscles of the lower esophageal sphincter and not cut mucosa. What you're seeing on the left is the steps of the procedure on the y-axis. And you see a straightforward case, sort of moves like a stair step from the first to the last step. The red line is the line of what the surgeon said they were doing. The blue is what the algorithm thinks the surgeon is doing. Straightforward case, you get a lot of concordance here. It's about somewhere between 90 and 95% in terms of overlap. Second case is a little bit more complicated. It's a little bit more of an end-stage procedure where the patient's more complicated, much more difficult anatomy. And when you look at the graph on the left, it looks a little bit different, right? So the surgeon still says that they're going from step 1 to 2 to 3 to 4 to 5, but if you look at the algorithm, it's kind of a little bit all over the place. And when we were first looking at that, we thought, oh, well, this algorithm doesn't work very well in complex scenarios, right? Thomas Ward, who was our fellow at the time, went back and looked specifically at the data. I think this is the pointer here. So, for example, like right here and right here and right here, where we thought there were mistakes, actually turns out that the surgeon was accidentally burning muscle or doing a myotomy while they were intending to do the tunnel, and we had sort of missed that in the labeling, but the algorithm caught it. Right? So that sort of gives you the initial indication that you can start looking for some of these potential adverse events. And so that's what led to the work that Ermine had done, where I'd shown this, which is based on if you were to ask experienced surgeons, so these are surgeons like Michael Brunt, Steve Strasberg, who first described the critical view of safety, and show them a video of a laparoscopic cholecystectomy and ask them, where would you start your dissection? What you see on the left is what they say, right? Now, obviously, not every expert agrees on exactly where they want to start their dissection, so you see a heat map of agreement. But you can take those levels and then train models to then replicate that. So if you ask surgeons, where would you go and where would you not go, the result is that you can then start to do some inference around where is safe and unsafe or even unseen data. What's great about what Amin has done with this work is that he has tried to make it more accessible. And so he has made an iPhone, an Android app where you can practice and learn about this, because it's really about not just building algorithms for the sake of building algorithms, but it's really to try to distribute that knowledge and that type of learning. And so you can move through different levels, and it will also use the algorithm's determination of what was safe and unsafe, and it'll give you a score, right? And so each level that you go through is going to be an increasing difficulty until you can match the difficulty of how very experienced consultant surgeons might do this case. What's interesting about that, so I mentioned, it doesn't tell you, well, it's because you're saving time, you're going to save 5 minutes off your commute, right? We as surgeons, we sort of think about surgery, maybe not explicitly in this way, but I would say at least implicitly, many of us operate in this way, right? So you get access into the abdomen, you evaluate the surgical field first, right? Then what do? Well, you have to orient yourself. So you might want to identify major organs as your landmark and then figure out up front, before you ever start your dissection, where is it unsafe? I don't want to go there, right? Once you figure out what's unsafe, then you figure out, okay, well, let me expose safe. I'm going to do some retraction. That's that third image here. And then I want to expose a safe area of dissection. And once you do some dissection, well, then you start identifying anatomy, like the cystic duct, for example, your hepatocystic triangle, until you achieve this next landmark, which is, okay, now I know exactly where my hepatocystic triangle is. And then you repeat, and you keep going and going and going until you identify all the different structures that you want to achieve as part of your dissection. Well, this is actually what's underlying, right, our mental model of how to do safe surgery. And yet this isn't explicitly taught to an algorithm, but this is what we were trying to achieve when we were training the go, no-go zone algorithm. We asked surgeons, label for us what's safe and what's unsafe, but we didn't specifically tell them to also label why they were doing so, because we knew that this is sort of what their mental model was trying to do. And so once you have this, what we're then able to do, and I have to give credit to Eric Wong, who's a colleague of mine in the School of Engineering who works specifically on explainability, is to say, well, actually, can you build a wrapper around our existing deep learning models? And he used a technique called sum of parts modeling, to then say, okay, well, I need to know what's contributing to this prediction of safe and unsafe. Well, what do algorithms do? They tell you which pixels are contributing to safe and unsafe, which means nothing to a surgeon. But those pixels are part of different organs, right? So if you tie that together with an organ segmenter, now what you start to give people is, oh, actually, this is safe because your hepatocystic triangle is here. This is unsafe because of the position of your hepatocystic triangle and the position of other organs. And so therefore, we can start to give you some explanation of why this is safe and unsafe so that you can determine and figure out, do you want to listen to the algorithm at this time, right? Do you want to take option A or B that Google Maps or Waze is going to give you as you're doing your dissection so that you can do so safely? And this type of algorithm is actually, what's really nice about this approach is that it's scalable. So we've shown the same type of thing in chest x-rays when radiologists are trying to analyze chest x-ray for things like pneumothorax, and even for tabular types of data when we're trying to do risk prediction, to try to give some explainability around this. Interestingly enough, though, when we asked surgeons, like, hey, does this mean anything to you? The answer was no. We still don't like this. And so now what we're working on, one of our students is now tying this individual language models to actually give surgeons auditory feedback. So to explain to them as they're dissecting, like, yes, you're in the safe plane because your cystic duct is here, et cetera, et cetera, et cetera. So that's sort of like what we've been building on. And we've been trying to expand this concept across different types of procedures. So ASGE, which is our American Society of Gastrointestinal Endoscopy, has funded us to build out these similar models for POEM and ESD, so submucosal therapies. And we see that they're similarly as effective, even initially on small amounts of data. And we've now since grown our data set even larger and have better performance than this that we're going to present at Digestive Disease Week. Just to sort of tag in what other really great researchers are doing, Andrew Hung, who's now at Cedars-Sinai, has really been the leader in tying some of this work to outcomes. And so he's a urologist, and he studies robotic prostatectomy. And so he was able to take visual identification of specific actions that are taken during a robotic prostatectomy, and this is represented as a graph right here. And he's able to compare the two and look at functional outcomes in a patient 1 year after surgery. So just by looking at what the surgeon did over the course of an operation, he is able to predict the patient's erectile function and continence 1 year after nerve-sparing prostatectomy. And so as part of that, he's able to then break down what we know intuitively as surgeons, right? If you're dissecting near a nerve, don't use cautery, right? Because you have a chance of injuring a nerve. But that's one of those things that's just sort of passed down dogmatically when you go through surgical training. And he was able to show that quantitatively. Yes, no surprise that when you do that, it has a specific effect. But that's very different because now he can go back to a surgeon and say, hey, do you know why your patients have a worse outcome? Because of exactly this thing that you're doing in the operating room. So to get a better outcome, we need to modify your behaviors to match this profile up here, where they have better outcomes at 1 year, than what you've been doing the whole time. And that makes surgeons much more receptive to getting that feedback than to just saying, hey, I think you're using too much cautery. It's no longer I think, it's I know, right? We're building on this within our own group to better understand general surgery procedures. And so even though I'm not an HPB surgeon, we have a big collaboration with the University of Pisa in Italy. So this is for robotic Whipple, where we're doing specific tracking of the needle points in combination with the outcome data that we have for patients around pancreatic leak. And then working with Kostas Danielidis, who's a professor of computer science at Penn, who does a lot of 3D geometry work, to better understand, conceptually as surgeons, when we think about anastomosis, you can imagine it's connecting two cylinders, right? Now, we know that in real life they're not two cylinders, these are deformable structures, but if you're able to take this type of, let's see if I can get this video to work, maybe. Yeah. So we know that if you can take this type of deformation and calculate the 3D mesh around this, you can do some interesting tricks around deformability and trying to understand how your cylinder, quote-unquote, perfect cylinders are potentially going to align, and then also calculate what is the estimated torque and shear that you may have as you're bringing these two structures together. Is that having any type of impact on your potential leak rate? So really things that we weren't able to do traditionally in open surgery because the visualization is very different than what you might get in robotics, to really try to better understand some of the things that we've taken for granted, right? Pancreatic leak, everybody just kind of shrugs and says, well, this just happens after this surgery. And then the question becomes, can we actually more specifically quantify what's happening during that part of the procedure to better understand whether there are ways that we can improve that? Now, all of this takes a lot of labeling, right? So those of you who have done this type of work know it's very, very painful to sit there and label each of these images and frames. Fortunately, things have improved. There are a lot of things, for example, commercially available. Segment Anything is an open source model that can segment a lot of these structures. But there are also techniques that you can use. So Guichu Liao is one of my postdocs, and he is really interested in questions around weakly supervised learning to try to scale some of these approaches. And weak supervision is really having sort of some very coarse or rough labels around what may be happening. And traditionally, when you're looking at video, what you have is something where you might say, well, in this video, there's going to be a hook. And when you look at these traditional data sets, the problem with this, what we call constant object presence, is that saying that there's a hook in the video assumes that that hook shows up in every single frame. But that's not truly what happens in surgery, right? Instruments come in and out, and you can move these things around, and they may come out of view in some frames and come back to view in others. That's what we call transient object presence. And so right now, most of the labeling that gets done is at the image level, so every frame gets a label of what's happening. So then the question becomes, if you don't have this, but want to get this in a semi-automated fashion, can you just say, hey, there's a hook and a grasper in this video, find those for me, and how does that work? And so he's going to present this at the winter conference on applications of computer vision. It's happening in Arizona, but basically you're able to structure these models in such a way that you can use a technique called knowledge distillation to say, well, I have a network that's very good at identifying specific types of structures. Can you then train a much smaller, sort of more efficient network to learn from that bigger network and try to parse out, I know there's going to be these instruments coming in and out of view. Can I take the very most important lessons from this to identify which frames have that instrument, and then as needed call those together so that you can achieve automated labeling without some human being having to go look and identify each and every single one of these instruments, so that we can train these other algorithms to help us with our applications. And so we've been able to really beat state of the art in terms of frame level accuracy from video labels only. So there's actually not specific labels on each and every frame. This is sort of the type of accuracy that we get when we just say, hey, this video has these instruments in it, find these for us. And that has really sped up our workflow and our pipeline for trying to get more and better data that we can train off of for the other types of applications that I just showed. Weakly supervised approaches are not new. In fact, I would argue that some of the other fields in medicine have been using it for much longer. So work that's been done by the cardiologist has used weakly supervised learning to try to improve risk prediction. So this is a paper that was published in the Journal of the American Heart Association, where they looked at 1,300 patients and tied together phenotypic and genetic variables on top of the usual clinical types of things that they would look at. And they were able to cluster these patients together in a weakly supervised fashion. And what's interesting about this type of work is that some of these things might be obvious to us as clinicians, right? So when we think about who are the highest risk patients to undergo an operation when they have cardiac comorbidities, not surprisingly, the oldest patients might be, right, the most comorbid in the sense of having prior stroke, peripheral artery disease, heart failure, etc. What I would argue we can't do as easily as clinicians is to look at the entire genetic and phenomic profile of those patients and say, okay, these are the things that are going to be most related. And if you take somebody who's in the youngest group, right, are there certain things that you can find that are going to contribute to that risk so that you can more specifically counsel these patients and what may be high risk or low risk surgery for them, even though it may not be intuitive to us as surgeons that a young patient is going to be at slightly higher risk than somebody who's middle-aged, depending on their other characteristics. And so I think that's to say that there's a lot of different elements, that this isn't just about sort of finding images and using images in video. We can also incorporate all these other types of things into our analysis as surgeons. All right. One last thing in terms of other groups. So this is the question that I get asked a lot, which is when are fully autonomous robots coming? So they already exist. Ken Goldberg, who's at UC Berkeley, has been doing this work for a very long time. So this is an example of his work. This is actually from, I think now 6 years ago, of a robot that is doing this totally autonomously. There's no human being controlling these actuators, right? It is passing stitches. If you're watching this and you're a consultant, you're probably like, boy, this is really slow. And this is sped up 4x already of what they were already doing. So you can imagine how painful this is. But it's still impressive nonetheless that the way, loading the needle, making sure that it's not getting tangled up in the suture, passing the needle through the tissue, following the curve of the needle, right? These are all things that we teach our trainees to do, and we often have to harp on them on how to do that, right? What I love about this is he also has a video of all the failure modes. And so he jokes, he's like, oh yeah, this is my one take out of like 100,000. The other ones I don't show. But he has videos of the takes that you're like, oh, this thing is like, you could put in a horror movie in terms of like how it butchers this type of tissue. But I think it's to say that, yes, it's possible to do autonomy in terms of like, can you technically do it? The reliability of it and the efficiency of it is a whole nother question. And as we continue to improve our sensors and our understanding of how you can improve planning, motion control, actuation of all these steps, that's where you're going to see some significant advances. But I would say sort of at the base level, the basic concepts around autonomous robotic surgery are there. It's just how is that going to improve and roll out to the point that it is safe enough for us to trust it, right? Other things is that we know that a lot of these algorithms, we're having to train individual algorithms for each type of surgery, right? There's a chole algorithm, there's a colectomy algorithm, there's a this algorithm or that algorithm. That's not how we learn, right? When you learn to tie a stitch, you don't have to relearn how to tie that stitch when you're going from an appendicectomy to a gallbladder to a paraesophageal hernia to an abdominal wall hernia, right? And so why is it that we're doing that for our models when the reality is there are lots of techniques in the machine learning community about trying to build off of that so that you don't get this phenomenon known as catastrophic forgetting when you try to add in new tasks to a given model. And so some of the work that we're doing is on trying to understand, well, can you take lessons from, for example, laparoscopic cholecystectomy, which we have a lot of data about, and then transfer that to robotic chole, which we're starting to get a lot of data about. Can you do that similarly for more complex procedures like paraesophageal hernia? And then more interestingly, can you actually cross procedures and say that lessons that you learn from chole, do they advance to other procedures? Or if you're thinking about even across modalities, in endoscopy, when you look at something like POEM or ESD, when you're doing a benign case versus a cancer case, but they're very similar techniques, can you build algorithms that are extensible across these types of procedures such that you don't need to rescale all over again in your annotation labeling efforts? And part of the problem with getting to this is that there are significant obstacles to clinical translation. So one is that a lot of our data is biased, right? We generally have fairly small samples of data in our work. This is not like self-driving cars where we have millions and millions of miles worth of data that is being collected every single day. I'm sure there's going to be a lot of discussion today about collection efforts of data and sharing efforts and things like that. But the reality is that we're leaving out a significant number of people just in the way that our healthcare systems are set up. Certainly in America, there's a big problem with how you cover care, right? We don't have really a true public option in the way that many European countries have. And so there are a lot of patients that never come to the hospital because they can't afford it. And so those people are being left out of these data sets. And the question is, are the algorithms that we're building scalable, generalizable to that community of patients, or are we going to continue to systematically bias against them by building these models with the patients that we see just by convenience coming into our hospitals? The other portion of that is how do we evaluate these algorithms? And are we evaluating them from a sort of technical aspect around like what do we think as computer scientists needs to happen in terms of understanding performance of a metric, or do we want to evaluate them as clinicians? Is it something in between? We all know that numbers are not the same, right? All numbers are not created equal. You think about BMI, right? If you think about somebody with a BMI of 32, that can be an obese patient, or that could be like Dwayne "The Rock" Johnson, right? Similarly, age doesn't tell you everything either. So if I told you that a 40-year-old male can play basketball, and I ask you, hey, would you want a 40-year-old to come play basketball with you on your team this weekend? The person who shows up on the basketball court might be this person, or it could be this person. And we know that the performance is not going to be the same between these two individuals because we know that 40 years old is not equal to 40 years old in terms of performance, right? The problem is that when we pick metrics for evaluating our algorithms, that's also not the same, right? And so Lena Meyer-Hein, who's at the University of Heidelberg, led a very big multi-institutional international effort across 60 different institutions to try to identify pitfalls around the metrics that we're currently using to evaluate our algorithms. And so an example of this, right, if we think about radiology algorithms that are trying to detect tumors, in MRI, we might look at this algorithm and say, hey, that looks pretty good. Our voxel level sensitivity is 0.94, right? But that's not the clinical question. That's the technical question, which is how good are you at identifying lesions? The clinical question is, can you identify all of the lesions? So if you look at this example over here, in the reference image, there's a tumor down here in the bottom left of the cerebellum. The algorithm misses that. So if you're looking at instance level sensitivity, it's 0.5, which I would argue is a more clinically relevant way to assess the performance of this model, because as a clinician, you don't want to miss a metastatic lesion, right? And you have to worry that some of the incentives are placed in the literature, for example, around trying to get better and better performance. It might incentivize publishing this number over this one. And so near perfect voxel level sensitivity is really hiding the performance at the instance level for these individual machines. Similarly, when we think about from a surgery perspective, DICE is something that we use quite a bit to try to understand overlap between what our machines predict and what the reference was in our ground truth. So if you take an example from a cholecystectomy and you say, well, I think this is the cystic duct, and you can also say, well, I think this is the cystic duct, that will give you the same DICE score, but I would argue that as a clinician, that green box matters a lot more if I have a trainee doing this dissection following some model than the yellow bar, right, where they risk actually putting a hole in the duct itself and potentially leaving a leak or complicating the operation. And so we have to understand what the limitations of these different metrics are in the context of what our clinical goals are. And so what's really happening here is that there is really a difference in what we're trying to achieve, right? So in some of the venues in which we're talking about the work, we may actually care about the pixel level performance of some of these algorithms, because what you may want to improve is, hey, can I specifically identify this lesion? But when we implement it in the real world, we probably care more about object level. So it matters less to a clinician, to a radiologist, for example, that every single pixel is correct, right? Because a clinician just needs to be told, hey, a couple of these pixels might be a cancer, and then you can extrapolate from your own experience as a human being. But if you're missing lesions entirely and not drawing attention to those, that's probably going to be a bigger problem. So when we're setting up for these problems, we need to ask ourselves, what is our ultimate goal, right? Similar things can happen even if you don't think about imaging problems. When you think about class severity, right? So let's say you have a disease. 0 means you don't have the disease. 2 is severe disease. 1 is like sort of halfway there. Think about diabetes, right? How severe is your diabetes? How severe is your obesity? Right? So if you take a reference here and you're just looking at accuracy, these two algorithms are going to give you the same accuracy, right? So 2 of 3 were correct. But the problem here, if you look at prediction 1, right, yes, it was wrong because it's class 2 patient, but this algorithm classified this as having no disease, whereas algorithm 2 says, well, they have disease, it's just not as severe as the actual disease. So what you want is an algorithm where the expected cost of missing, right, is lower, even if the accuracy is the same. So at least you're identifying the disease, even if you can't specifically get the severity of it correctly, right? So it's thinking about all of those different elements around what is the problem if you miss on your prediction, and how much do you miss by? And going back to this example of sort of representation in data, going back to DICE, for example, so the representation in terms of the amount of data, or the amount of your target, for example, right? Bigger structures are going to overweight when you look across different patients, so that if you have an algorithm that has an overall DICE of 0.8, you're heavily biasing on examples where you may have more data or larger targets to try to hit, and you're going to leave out these other patients where if you take it at a per patient level, your actual performance is a little bit lower. Right? So we need to think about, as we evaluate our algorithms, how we may be systematically excluding or biasing some of our approaches. And so the overall framework is to say, this is the important part of clinician involvement, because the underlying biomedical problem is what drives how we decide the recommendations that are made around how you evaluate these algorithms and how we want to think about their performance. This is hopefully not just too abstract of a topic, because if you're evaluating a paper and you want to know about the metrics, Lena has made a very easy to use tool online that you can go to, and it'll ask you, what the questions are and what matters. Does it matter, that you identify the structures? Is there overlap between the structures? It'll actually walk you through and give you a recommended set of metrics that you should be thinking about to evaluate that paper that you've been asked to review, or if you're trying to think about where this is going to apply overall. We know that this is also different for video versus still images. So with Fiona Kolbinger, who's at Purdue, we're collaborating now and trying to extend this out to try to understand at the video level how should we be selecting these different types of metrics as well. And then finally, just to close, just about this piece on literacy. So as we have continued to build this out, and as these algorithms and different tools become more and more ubiquitous, it becomes very, very important to have some understanding of how these things work, right? Because this is no longer locked into this development phase where researchers and engineers are just doing this in silos. This is now coming out to many of you who review for medical journals. And this is basically the appraisal mechanism, right? So this is the possibility, this is where things stop or go forward. Because, you've all seen the press releases, right? Paper is published by so-and-so that says AI is going to do this, that, or the other. Because that gets picked up by the lay press. And that's actually what gets disseminated to patients and most practicing clinicians. And so this is actually a very important step here to make sure that there aren't mistakes, like what I talked about in terms of metrics, in terms of overstating the abilities of some of these algorithms, or making sure that they align with our clinical goals. And then even if you're not at this place, if you're here using these algorithms, you need to interpret how you're going to use these so that you can use them effectively. You don't prescribe a drug without knowing its side effects or knowing its efficacy, right? So why would you use an algorithm without knowing the same kinds of problems? And so it becomes important to get that sense. And so we've been working with Chiara Langoni, who's now at Bocconi University in Milan. She had initially done a lot of this work with the U.S. government, where she was looking at, what does it look like when you ask people how much they know about AI? And so not surprisingly, if you take U.S. government officials, those who rate themselves subjectively as having high amounts of AI knowledge, objectively have very low AI knowledge. The dangerous part about that is those were the people who are most willing to use AI to solve problems, right? And the people who were rating themselves subjectively as low had objectively higher AI knowledge, right? So the more you know, right? And those are the people who are least likely to want to use AI to solve this, that, or the other problem. And so we're trying to better understand that in healthcare as well for healthcare applications. And we're seeing similar trends. And that goes back to the point in terms of appraisal and use, right? So it becomes really important to get that knowledge so that you can use these things safely. And I think at the end of the day, all of us who are here are interested in these topics because we understand that there's a lot of data, right? And we understand that there are applications for that data. And more importantly, we're interested in the implementation of the applications of that because most of our lives are spent treating patients. And so the goal here is really to get translational surgical data science where we can take things across the continuum to ultimately improve the care that we're delivering to our patients in a data-augmented way. And I think the way to do that is through meetings like this where we can convene multidisciplinary experts to talk about what are the potential pitfalls and what are the true sort of hopes and potential that we have to build on this and try to create this safer, better world that we all want to live in and that we all want to see our sort of children, grandchildren, etc. go on to create and build. And so, again, thank you, Ronan, for convening this because it really provides us a unique opportunity to have that discussion into what it means to build this world. And so with that, thank you very much, and I'm happy to take questions or feel free to reach out. Thank you.